All right, we're recording. Hello, everybody. Welcome to our first update for our ValEAR trial. We're going to go over a few things today. First of all, we want to introduce ourselves. We have Albert Park, who is the lead physician on the trial for ValEAR here out of the University of Utah. We have Angela Shoup, who is our lead audiologist out of the University of Texas Southwestern. And then I am Ashley Wilkes. I am the manager over the ValEAR clinical trial here at the University of Utah. We're going to go over some important updates for all of our participant families. Some important information we think it's great information for you to have right now during these interesting times. First of all, I'm going to go over what changes we're making for you, your families, your safety during COVID-19. We're going to go over some changes to the study and then some need to have you reconsent for the trial later on. So changes right now during COVID-19. We are actually allowing for virtual visits as much as possible. So if your visit can be done virtually from afar, we are making that happen. We are also shipping study drug directly to you at home. And then your local study team will follow up with you over the phone and go over any instructions or questions you may have. And then also any lab work that's required. We are trying to accommodate as much as possible so that you can do lab work locally, closer to home, as much as possible as well. We want to make it easier for you to follow up on the trial and keep your baby safe. Okay. Dr. Park, take it away.
Thanks, Ashley. Yes, my name is Albert Park. I'm the principal investigator on this trial. And thank you very much for listening in on this. I think the success of this trial has really been a tribute to the efforts of our team, our research team, as well as the families and the children involved in this. I did want to say a couple of things before I get started. One is that our #1 priority given the COVID crisis is your safety. This has been an unprecedented time. It's been very challenging. And Ashley hasn't mentioned this, but she's put in a lot of effort as well as other members of the team to try to determine ways that we can minimize exposure of our families as well as our research staff to this devastating, awful infection. And so those are the sort of items that she outlined to you. I also want to thank you that in this difficult time that every single participant has been able to stay on the trial. And in fact, every single scheduled visit has been has also been successful too. And again, that's due to everyone's efforts. Now, we really want to make this as informational to you as possible. This is really for you. And so we are going to just briefly talk about what we think might be of interest to you. And so I thought we would start about talking a little bit about congenital cytomegalovirus and hearing loss. And it's great that Angela Shoup, who's our co-investigator on our team, is also going to talk a lot more about the hearing measures, because that's really sort of the or the focus of this trial, and obviously an important aspect that we need to hopefully make clear to you for your child. Okay, sounds good. And so this slide really just mentions sensorineural hearing loss and cytomegalovirus. CMV is the abbreviation. And hearing loss, unfortunately, is a very common finding that we see with children with CMV. In fact, when we look at all the various different causes of hearing loss, CMV is near the top, and it may account for about 1 in 5 children with hearing loss. As a result of that, though, we have implemented in Utah and many states, including your institution, some sort of early CMV screening because hearing loss is so frequently presenting this way. We can use universal newborn hearing screening. So every child in the United States gets hearing screening at birth, and anyone who fails will then get CMV testing. And so that's what's called a hearing targeted CMV screening approach. And I think a number of the families who are participating, their children were identified through that means. Another way that you can identify these children is if the child again fails your newborn screening, it's found to have a hearing loss, and then you can do what's called a dry blood spot test. to identify whether the infection may have caused your child's hearing loss. So these measures and these efforts really revolutionized our approach toward identifying children earlier. And this is an ongoing process that we're trying to sort of refine and improve, with the hope that maybe someday we'll get to universal CMV screening. But at least in the United States, we're not quite there yet. So the next slide, Ashley, if you don't mind advancing, thank you. I'm going to now let Dr. Shoup talk a little bit about hearing testing, because I think you've all had the experience of your child undergoing the testing. And so I want to go into a little bit more detail about what that entails and why that's so important.
Thank you so much, Dr. Park. Most of you have encountered newborn hearing screening at this point in time. And when infants receive a hearing screening at birth, they will have been screened with either otoacoustic emissions or auditory brainstem response technologies. Both of these tests will provide an objective estimate of hearing function. And for both tests, the infant must be very still and very quiet. The test environment should be relatively quiet, and typically the screening test in those situations will not take very long. When you think about what's required for a good screening test, we'll be talking in a few minutes about the diagnostic evaluation that will occur for a child that needs further exploration of their hearing capabilities. And these are all factors that are also extremely important when we look at evaluating the hearing system or the auditory system in general. If your infant was screened with otoacoustic emissions, it would have been very similar to the lower right-hand corner picture. That's a child, an older child, receiving OAE screening. And OAE testing involves having a very small probe, similar to an earplug, placed in the ear canal. The probe has both a sound generator and a very tiny microphone. As sounds are presented in the ear canal, responses from the inner ear are collected and analyzed. And when I mention the inner ear is the snail-shaped structure called the cochlea that you may have seen on some anatomical charts before. One of my professors used to call this the ear ball because the cochlea is very much similar to the eyeball, except for it's in the auditory system. The cochlea, or that snail-shaped organ, houses the sensory organs of hearing, and these sensory organs are referred to as hair cells. The otoacoustic emission test provides information about the function of the hearing pathway, the auditory pathway, from the outer ear, or your pinna, to the all the way to the cochlea, or the inner ear, where the hair cells are located. For the auditory brainstem response test, which you can see in the upper left-hand corner, a picture of a baby receiving auditory brainstem response testing. Little sensors, sometimes referred to as electrodes, are placed on the head, but they're essentially sensors that are placed with kind of a gel pad, a little sticky pad to hold them in place, to keep them attached to the skin. They're very soft, sticky pads with kind of a water gel-based adhesive holding them in place. These sensors are placed to pick up brain activity that is elicited by sounds presented through the earphones while the baby is resting. This test will provide information about the auditory pathways from that inner ear to the upper levels of the brainstem as sound is being processed by the brain. In screening with either otoacoustic emissions or auditory brainstem response, a stimulus is presented at a single loudness level. So for a screening test, you're not looking to find the softest level at which a baby can hear. You're also not looking at how the baby hears for a bunch of different pitches. You're just looking to see if the baby should have additional testing. So a single loudness level is presented, and if a response is obtained, the infant is said to pass the test. But if a response is not obtained, the infant is then referred for further testing to determine if there is a hearing difference, and if there is a hearing difference, to characterize the infant's hearing ability and determine any recommended treatment approaches. Next slide, please. When an infant refers on newborn hearing screening or is suspected to have hearing difficulties, it is necessary to then determine the softest level the ear and the brain can respond to sounds at a variety of pitches. Sounds are made up of many pitches. So think of the span of a piano keyboard and the many keys on the piano keyboard. There are way more hair cells in the inner ear processing the very small differences in pitches of sounds that we hear as humans. To hear and appreciate the music that you're listening to, you need to be able to hear the low pitch tones, the mid pitch tones, and the high pitch tones. Speech is very similar. It's also made up of multiple pitches. When you think about the loud, low pitches, think about the vowel sounds. Ah, ee, oo, ah. All of these sounds are produced by using voicing. I use my vocal folds to produce a sound that I then emit through my mouth. The consonants are very high pitched. They're on the very high treble end of your piano keyboard. They're also much softer in most cases because for many of these, we do not even use our voices to produce them. All we do is simply restrict the airflow at various points in the vocal tract. With hearing, it's possible to have perfectly normal hearing for one pitch and have significant hearing difficulties for other pitches. And for many conditions, it's actually the high pitches that are more affected by hearing difficulties. So you may have an infant or a child that hears perfectly fine in the low pitches, but they can't hear the high pitches at all, and they won't be able to develop speech and language appropriately in those situations. This is why it's extremely important for us to determine how well an infant can perceive sounds of multiple pitches across the sound spectrum. And in most cases, we are much more focused on those high pitches if we're not able to get all the information necessary. So for this reason, a diagnostic ABR is going to take a lot more time than a screening test will take. For a diagnostic ABR, the softest level at which sounds are processed by the brain at multiple pitches must be determined. So on the left-hand side of this screen, you can see a graphic of the auditory nervous system pathways from the cochlea, which is the spiral shape here, and it has kind of a Roman numeral 1 near it, all the way up through the brainstem, on up to the midbrain, on up to the auditory cortex. And so the auditory brainstem response starts testing at the distal portion of the hearing nerve as it leaves the cochlea, and then it tests these auditory pathways all the way up to this Roman numeral 5, which is in the brainstem area. It's important to remember that the auditory brainstem response is not a test of hearing, but it is a test of neural synchrony of the auditory pathways from the cochlea, or the inner ear, to the upper levels of the brainstem. However, research has indicated that for most individuals who do not have nervous system diseases or disorders, the auditory brainstem response can be used as an estimate of hearing sensitivity. On the right-hand side of this slide, you will see an auditory brainstem response test from a 1-day-old infant to one type of sound. This was actually a click stimulus, but you could have this for, let's say that this was 2000 hertz, or a high-pitched stimulus. The Roman numerals on the waveforms reflect the generator sites on the auditory brainstem response. So where you see the wave 1 response, let me see if I can highlight that for you. I don't know if you can see my mouse movement or not, but where you see the Roman numeral 1 on the waveform, it reflects the Roman numeral 1 down here on the graphic of the brainstem pathways. The top waveform that you see, the very large waveform, is to a pretty loud sound. It's to a 60 decibel sound, which is a pretty much loud conversational speech level. The red waveform right below that is at 40 decibels, a little bit softer. The purple is to 30, which is a little bit softer again, and the green is to 20. That is the cutoff for normal for testing with an auditory brainstem response test. This is the estimated equivalent of the softest level perceived by a normal hearing infant to that sound. What you might observe by looking at this is that as the sound gets softer, the waveforms become less distinct and much smaller. During an auditory brainstem diagnostic evaluation, this type of process will be completed for each ear at multiple pitches. They will present a loud sound at a pitch, and then they'll gradually reduce the loudness of that sound until they can no longer see a very good response. In each of these cases, they'll have to repeat or collect at least multiple times the same response to make sure they have a true response. So the audiologist will be obtaining responses at louder levels and at consecutively softer levels to estimate the hearing sensitivity of your infant to various pitches. It's extremely important that they're able to test not just multiple pitches of sound at multiple loudness levels, but also each ear individually. So the test can be quite lengthy, and it will require possibly an hour, hour and a half, possibly in some cases 2 hours to complete the test. But what's most important is that the baby must be cooperative. So to increase the possibility of getting as many responses or learning as much about your baby's hearing as possible within one test session, it's extremely helpful if you bring your infant to the test in the best date possible for them to sleep for an extended period of time. So one thing we typically will suggest is that you try to schedule your appointment near your infant's normal nap time, You try to plan to feed your infant when you arrive at the clinic or right after the audiologist has prepared your baby for testing, attached the little sensors and gotten the earphones set and everything of that sort. And try to keep the infant from napping on the way to the test. It's terrible to get to the test site and find that your baby's asleep in the car seat. As soon as you wake them up, they're not going to go back to sleep for a number of hours. The longer your baby can stay in a very still, quiet sleep state, the more information will be obtained and you'll learn much more about their hearing. It's also important that you turn off any electronic devices such as cell phones during testing, because these can cause interference, which will affect the test results. Next slide, please. This is just a little bit of additional information about otoacoustic emissions. Otoacoustic emissions, as I mentioned before, are a recording of the inner ear's response to sound. They will often be completed in conjunction with an auditory brainstem diagnostic evaluation. They sometimes may also be used as a complementary test for the behavioral evaluation, which we'll talk about next. This does provide some valuable information about the integrity of the sensory organs of the inner ear. However, otoacoustic emission tests cannot be used to predict or estimate hearing sensitivity at various pitches, such as an auditory brainstem response can do or behavioral testing can do. So it's used as a very powerful complementary test, but it is not used as a replacement test for either of those diagnostic evaluations. Since once again, it's very important to find out the softest level at which the brain is able to process sounds of multiple pitches. Next slide, please. Okay, so the gold standard for hearing assessment is behavioral evaluation. Many of you have probably had your hearing tested at some point in time. It may have been when you were in school and you just had a quick hearing screening. Others may have had a full diagnostic hearing test. For school hearing screenings, what you may remember is they may have set you down in a chair and asked you to raise your hand whenever you heard the sound. And they usually presented at one loudness level at multiple pitches, and you would raise your hand whenever you heard the sound. Well, as you can probably predict with your child, it's not really possible for us to get a 6-month-old or a 9-month-old or even a 12-month-old to raise their hand on command. So, and it's not possible to help them understand that we want them to respond to the softest sound that they hear. It is still possible, though, once a child is neurodevelopmentally about 6 to 9 months of age, to get them to start participating in behavioral testing. So what we typically will do is when the child reaches the point that they can move their head volitionally and they have enough neck strength to carry their head unsupported by the parent, we will teach them to respond to the types of sounds that we would like for them to respond to by reinforcing a desired behavior. The first approach that we use to test hearing behaviorally, since they reach a volitional head control between 6 and 9 months of age, is to teach the child to turn their head whenever they hear a sound. So when they get into a sound attenuating booth, we can place them in the room and present sounds either through loudspeakers or through earphones. And whenever the child turns their head in response to hearing the sound, they're given the opportunity to look at a visually attractive toy that lights up or may become motion activated, or they also may have an opportunity to look at a video clip. If they turn their head automatically to the sound when they hear it in the sound booth, this is reinforced by showing them these objects. And then once they become interested in something else, they are no longer staring at the toy, we will present the sound again. So what you can see in the picture on the left-hand side, the darker picture with the dad holding his child, is the dad is manipulating some toys in front of the child. When the sound is not being presented, it's important to keep the child from looking at the test box, or the reinforcer box. So we essentially will have either a second clinician in the booth with the child that's manipulating toys and keeping the child focused on something other than the test itself, or the parent, you may be asked to hold a book in front of the child or hold an attractive toy in front of the child. The responsibility of you, the parent, if you're participating in the test, or if you're in the room with the child during the test, which you will be, is to make sure that you do not cue the child that a sound has been presented. So try to be sure that you don't turn your head or turn your body or shift or move or tap them or let them know that a sound has been presented. Just keep manipulating the toys in front of the child midline. Once the child has heard the sound, it moves on to the lighted up picture on the other side. The child hears the sound is presented, the child hears the sound, turns their head in response to the sound, and they get to see the toys. After they've responded, we wait until they're now once again interested in whatever is being held in front of them and they're no longer looking at the toys, and then the sound will be presented again. This will be done for multiple pitches and multiple loudnesses. And once again, for every new pitch, the sound will be presented at a nice loud level to make sure the child can hear it and responds easily. And then gradually the loudness of the sound will decrease until the child no longer will turn their head in response to the sound. Let me see. This will be repeated and reassessed multiple times to ensure that the child has responded with a true response and we didn't just have an accidental head turn that we thought was an actual response. The child will then also receive some social reinforcement, a little bit of cheerleading as we go. Once the child reaches about 2 years of age, they will quickly reach the point where they're bored with being tested in this manner. They may look at the toy a couple of times and then they figured out what the toy is and they no longer want to turn their head when the sound is presented. So between about 3 to 5 years of age, we can start teaching them to play a game in response to a sound. And you can see in the next picture, the little girl under condition to play audiometry. And what she is doing is she has been taught that when I am ready for testing, I hold a little block up. She's holding a blue block in her left hand. And when the sound is presented, she will then put the block on top of the other blocks. And then she'll get a new block. If the child either turns their head and a sound has not been presented or places a block when a sound has not been presented, they're given a little bit of timeout and they're not given reinforcement. So in this case, the child would be given the block back that they had placed on the tower and be made to listen again. We only have about 20 minutes or so with the child when they're going to participate in these tests. So it's very important to optimize our opportunities to get as many responses as possible. Some of the ways that you can help with this are to make sure in this case that the child does not come sleepy or hungry. So bringing a snack, feeding the child before their visit, making sure they're not coming at nap time, that they are getting a good night's sleep the night before testing is very, very helpful. We want them alert and in a good frame of mind and a comfortable physical state when they come in for testing. Another thing you can help us with though is, as I mentioned before on auditory brainstem response testing, we would like to know how each ear hears, not just how both ears hear together, because it's very important that we have 2 ears. If we bring in a young child for VRA testing and they haven't had earphones on, sometimes we're not able to place earphones on for the testing and we have to present just through a speaker. When we present through a speaker, it will only tell us about the hearing in one of their ear, whichever ear hears best. So if you have hearing that's exactly the same in both ears, you'll learn about both ears. But if you, for example, have perfectly normal hearing in your right ear and hearing difficulties in your left ear, we will not know about the hearing difficulties in your left ear. We'll only be getting the response from the right ear. It will respond every time a sound is presented from the speaker. So what you may want to try to do at home is let your child listen through earphones to some music, or maybe watch some of their videos or movies through earphones at a comfortable level, not at too loud of a level, so that they learn that earphones are not frightening. And then when they come for their audiologic evaluation, we'll be able to give you more information about hearing in both the right ear and the left ear. And once again, if you will bring them in a very quiet, calm state where they're well fed and not too sleepy or cranky, we'll get more responses to sounds in one visit. So you can learn more about how your child hears at low pitches, mid pitches, and high pitches. Another important consideration is, as I mentioned, we're trying very hard to keep your child focused on the test in the sound booth and have them listen for the different sounds. So making sure that you do not cue them is extremely important. But that also means that it's helpful if you can tap into your support group to have somebody maybe watch older siblings or younger siblings when you bring your baby for their appointments. Because young children often don't pay as good of attention in the test environment if they have another child kind of playing in the background or possibly cueing them. And many times other children want to participate when they see the toys. So it would be very helpful for you and probably less stressful if you had a support group member help take care of that child while you're bringing your other child in for testing. And that's also a consideration right now with COVID-19, in that many facilities will not allow other children to be brought to the appointment. Please feel free to reach out to us with any questions if you need additional information about preparing for testing or about your child's hearing. Thank you very much.
Thank you, Angela.
Great. Yes, thanks, Angela. Next slide. So Angela, I think, went over a number of really great points. You know, children are not adults, and so they can be really challenging to test. As any parent can tell you, they don't always do exactly what you ask them to do. And my kids were certainly not, were the same way too. She also brought up, I think, some important points in terms of really trying to get ear-specific and frequency-specific results. So you may have heard of a term called click ABR testing. We find that's certainly a reasonable test, but really to encompass the entire frequency range of a child's hearing, you need to do what's called frequency-specific or tone burst testing. And we've noticed even amongst our own great institutions in the ValEAR trial that sometimes not the entire range of frequency testing is being performed. And so I want to make sure you're aware of this, because when your child gets the testing, I want to make sure that we are as comprehensive and that we do the highest quality of testing for your child. What I want to also share with you is some relatively recent data. This was actually published in one of our otolaryngology journals, and this was a collaboration with the CDC as well as with Gail Demler, and she's a very well-known pediatric infectious disease specialist down in Baylor at Texas Children's Hospital. And really this came about because, as Angela mentioned, a lot of times kids, again, can be really difficult to test, and sometimes they just won't want to wear their earplugs, or you can't get individual ear threshold responses. Maybe you can only get the hearing in the better hearing ear. And so our question was, if you can only get the better hearing ear assessed, is that good enough, especially with congenital CMV infection or the kids with this? And why are we doing these hearing tests? You know, why are you going in and having these tests done? Well, it's because it's well recognized that not only do children with congenital CMV develop hearing loss, but unfortunately over time, this hearing loss can get worse over time. And so we want to be proactive and identify when your child starts to have any changes as soon as possible. So the next slide shows you just one example of, actually this one just shows you, yeah, here we go. This shows you an example of the sort of hearing test results over time. So this is a graphic. I don't know if the mouse shows it well to you, but the dark line shows you the hearing in the better hearing ear. These symbols indicate hearing levels, and this on the x-axis shows you the ages in years. And so this is a very common finding that we see in children with congenital CMV infection, in that one ear will seem to be better than the other ear, and that's confirmed on testing. The dashed lines here show you the ear with the poor hearing ear. And so what we wanted to do was, again, ask the question, if we just test the better hearing ear, is that good enough? Can we get the information early enough if the hearing were to change? Next slide. And so we looked at a relatively small number of children, but I think enough that tells us, if you look at these sort of these curves very closely, that the poor hearing ear, which are shown in the dashed lines, are the ones that actually change earlier, and they change more precipitously. They change to a much higher degree than the better hearing ear. Next slide. And we looked at this both in children who were born with hearing loss, as well as children who maybe initially had normal hearing, and then unfortunately their hearing started to get worse. We found that, again, the poor hearing ear, as shown very nicely in this patient A, actually the better hearing ear really doesn't show much change over time. And we follow these children really up to 15 years or through adolescence. But you can see in the poor hearing ear, as shown in the dashed line, that there's quite a big change over the first, say, 3 or 4 years of life, and then it starts to stabilize. You can see this also in patient 10. Not every single child in the delayed onset showed many changes, so that's reassuring to know that even though your child has a hearing loss, that doesn't mean your child is automatically going to get worsening hearing, but certainly we see it enough in these children that it's something that we monitor very closely. Next slide. So these are sort of the major findings that I wanted to share with you. One is that, unlike maybe other types of hearing loss, that children with congenital CMV infections tend to have what's called asymmetric hearing loss, where one ear is worse than the other. And that, again, it's easier to test the better hearing ear. And human nature would suggest that maybe we often will do that. But in children with congenital CMV infection, that's not a good idea. That you really need to check the poor hearing ear if you're going to be able to identify the changes in hearing sooner. And so this really changes clinical practice. And this is not actually, I think, necessarily common knowledge. I didn't really know this feature more than, say, a year or two ago. But this really changes clinical practice, because this then really provides ammunition for our audiologists to know that testing each ear is critical to identify changes in a child with congenital CMV infection. And that could mean harder work. That might mean having the child to come back again because maybe that day was not a good day for them. It might mean working with more than one audiologist to try to get this information, but the information that we obtained in the poor hearing ear is really, I think, crucial to not miss out on any changes. Next slide. So in terms of ValEAR and the study itself, I'm just reiterating sort of these sort of findings and our sort of experience in studying these children, that these are the sort of the major recommendations of what every single site. We have now about 25 sites, so this is truly a national study, and we are actually going to add Canadian sites as well as additional sites in New York and other regions of the US. So we're going to get to well over 30 sites as we move along. And every one of these sites, I think, are practicing the highest standards of clinical care, especially with hearing measures. And so, for instance, they're going to obtain thresholds in each ear, especially with focusing on the poor hearing ear. They're going to focus on these individual frequencies that we're looking at, sort of the mid to high frequencies, because we feel that these are the most suggestive of possible change from CMV infections. And we actually are having our research coordinators working with your audiologists at your various institutions to make sure that all these practices are followed closely. And then we're also trying to set up appointments if possible so that we can work with you and with the RCs and the audiologists to ensure timely testing of your child, as well as so that we can provide good oversight by our team in terms of ensuring the highest quality testing, again, for your child. I think this hopefully is a useful session for you and that you glean some good information from this presentation. We really take your opinions and your thoughts very seriously. I did mention on the prior slide some other potential topics that we could present, though I would be interested in hearing from you. PK stands for looking at drug concentrations. So really, we're very unique in that we are actually looking at the drug concentrations that your child is being exposed to. That is not common practice anywhere else in the US or even internationally. And we will plan to share that information with you in the future. And so potentially a presentation from our team about what that means, the pharmacokinetics and sort of the advantages of drug concentrations would be a potential topic in the future. Speech and language is very important, obviously, for your child. And so we have a team, actually of 3 outstanding speech and language faculty who can share their expertise and their sort of thoughts on what are our metrics, or what are we looking at, and what are the surveys that we will be providing for your child, and what they could mean in terms of helping your child's speech and language development. Next slide. And so these are just our emails. So again, feel free to contact us if you have questions. Again, we really would appreciate any feedback from you. And again, thank you again for your attention today.
Thank you, everybody.